So just a little bit about EDIT, we're the Evaluation Data Integration and Technical Assistance Program, and we work with a lot of you through a number of various projects, which we will get through on the next slide. But just some brief introductions. So I am Josh Bogner. I'm a research project coordinator. I'm here with Eric Glenn, who's the project manager for the Evaluation Center, and Gregory Phillips II, who is our program director. The Evaluation Center houses a couple of different projects. So the main one that we're focused on with this is the Evaluation Center 2.0, which is where we are providing evaluation and quality management support to the entire HIV services portfolio of Chicago. Along with this, we are also inviting our other partners from our other projects under the Evaluation Center, which includes the Community Development Initiative and Ending the HIV Epidemic, which these are our three main projects with the Chicago Department of Public Health. Outside of that, our evaluation and quality management work continues into EDIT Cares, which is one of our initiatives where we offer pro bono evaluation services to agencies who don't necessarily have the capacity or access to those services. So for today's session on HIV in Chicago, geography, disparities, and priorities, our session objectives are to review local rates and trends of HIV among intersecting identities. We're going to review place-based socio-structural determinants of health. Then we will explore health disparities uniquely aligned with intersectional demographics. And then from there, we will share opportunities and tactics to discover and address unique health disparities.
Good morning, everyone. The people who attended the talk a few weeks ago, I gave a quick overview of HIV epidemiology. I'm not going to revisit that too much in depth here, but I think it's a good way to tie what we're talking about today in with what we already presented and to give a good baseline for what we were talking about. So what do we really care about when it comes to HIV? And what are the people we're talking about? Here's a definition of who we really want to talk about. You can see there's a lot of different components here. We're looking for people with diverse characteristics, linked by social ties, share common perspectives, and who engage in joint action. And you can see this across the board in what we really all view ourselves as in the response to the HIV epidemic. So we want to talk a bit about community stakeholders in the response to HIV. And we're curious to know what you think this could be defined as. So we have four options here: people who live with HIV and those vulnerable to HIV, populations most impacted by HIV, people who receive HIV services, or all of the above. Which do you think is the correct definition for a community stakeholder? Yes, D is the correct answer. We really care about all of these things. We want to make sure everyone is involved in the response to HIV. It's not just the people who are vulnerable to HIV, but it's the groups that are most impacted by HIV, people who receive HIV services, and we're really interested in the population as a whole, not just specific individuals. This really collapses all of the figures into one slide. We see that lots of people are really impacted by HIV. We see that looking at by race, ethnicity, Black African Americans are the most highly impacted. And we see this across the board, regardless of what demographics we look at. If you look at the pie chart, the new HIV diagnoses among gay, bisexual men, you can see Black African American make up more than 1/3, so they are overrepresented there. And if we look at women, Black African American make up more than half of new cases. So we can see that there are overlapping groups that are impacted. And here we know that there's intersections between sexual minority status, racial and ethnic minority status, and those are the groups that are most highly impacted. So what we're going to be talking about a little bit more in the next slides are why these groups that are already marginalized are seeing higher rates of HIV and other negative health outcomes.
Perfect. So in this next section, we're going to focus on some geography when we think about Chicago. And so I will preface this by saying a lot of these things that we're going to cover on a few maps in the next slides, a lot of us who work in this field are very well aware of. I don't need to show you some maps to tell you that Chicago has a major issue with segregation and how that impacts our services. that being said, I think it's always a good reminder to kind of see exactly where some of these disparities lie. And so that's what we're hoping to do on some of these next slides. So on this slide here, we're looking at two different maps of Chicago. So the one on the left is focused on rates of HIV infection diagnoses, and the one on the right is looking at a rate of people living with HIV. So basically, the neighborhood areas that are marked in red have the highest rate of either people living with HIV or rate of new diagnosis. And then as the color goes down, there's lower rates. So as we kind of see, there's that area on the north side of like Uptown, Rogers Park, Edgewater, where we know that there's a high prevalence of HIV and also a high rate of infections. But then when we see, especially on this one on the left, you can see a lot of these areas on the city's south and west side that don't have necessarily as high of a rate of people living with HIV, but the rate of HIV diagnoses are continuously increasing. So when we think about where we are focusing our efforts, I think this is really interesting to note that a lot of the areas that have a lot of rates of HIV services are areas that have a lot of people living with HIV in those areas, but a lot of the cities, especially south and west side, there's just not access to services, as we all know, and these are the rates where people are experiencing higher rates of HIV infections. So this data comes from CDPH, and this is from their 2017-2018 data set. So this slide is just showing, again, talking about the segregation that's present in the city of Chicago. What this slide is showing is based on census data, and roughly in 2010, this is showing the predominant race and ethnicity by block in the city. So if you can see the color legend at the side, predominantly white blocks are highlighted with pink. The blue is going to be predominantly Black areas, and the orange is predominantly Hispanic. So you can see when we talk about Chicago being a very segregated city, that makes sense for people who do the work and who live in the city. But this map really showcases that, like, yeah, if you plot based on the predominant race and ethnicity by block, segregation is very clear just to the visible eye here. So especially when we think about services and culturally competent services, we got to be aware of what areas we're reaching out. And I'll leave you to look at that slide for a couple more seconds before we move on to the next slide. So this slide here, we're looking at from 1970 and 2017, average individual income in the city of Chicago. So there's an ongoing conversation about income inequality and wealth inequality in this country and in the city as a whole, and how the income inequality is something that's continuously growing in this country. So as you can see on this map, blue is going to be very high income, down to the lighter blue, which is just high income, all the way down to orange, which is very low income. So you can see that the city went from having a lot of what would be considered middle income areas in the 1970s, along with those high income areas along the north side, along the lake, and then some of those lower income areas, to 2017, just 3 years ago, where the south and west sides of this city are predominantly very low income, whereas the area that you can also map onto race and ethnicity, the area of the city that's predominantly white, that predominantly has access to a lot of resources, has only continued to see the income of its residents grow. So again, when we think about access to services and stuff, where should we be focusing on these things? Like, are more services necessarily needed in areas where there's very high income? And again, also, this isn't saying that there are not low income folks who live in the predominantly high income neighborhoods and vice versa, but the general trends are showing that these income inequalities are continuously growing in Chicago. And you can almost draw a line across that line on the graph and say, this area is high income, this area is low income. So definitely creates a major barrier there. So this is the last map I'm going to show in this section of the slide. So what we were looking at here on this map is the percentage of individuals living below 185% of the federal poverty line. So why are we using 185% of the federal poverty line? There's a number of reasons for this. So especially when we think about food insecurity and food deserts, people living at or below 185% of the federal poverty line are at a major risk of experiencing food insecurity. And as we know, when it comes to linking folks to services, helping people with their health, there's the competing needs and priorities when it comes to access to services. You're not going to be worried about your PrEP or your HIV medication if you don't have access to food, right? You're not going to, and also if you're lower than 185% of the poverty level, just how are you able to focus on like paying bills such as rent, food, all of this. So when we think about this, you can also see this just tracks with a lot of the other income disparities that we're having. I mean, you can see again on some of those areas on the city's south and west side, there's upwards of 82% of folks in those neighborhoods living at or below 185% of the federal poverty level. So this creates additional barriers and challenges as we move forward in thinking of engaging with services and clients, and just continuously showcasing the need for the work that we're doing and why we're all committed to ending HIV and also ending health disparities that are caused by income inequalities and other social determinants of health.
Thank you. So now we're going to talk a little bit more about the disparities I mentioned earlier in the presentation. I'm going to start off by talking a bit about the Youth Risk Behavior Survey. I'm not sure how many people on this call are familiar with the YRBS, but it's a biennial survey that the CDC conducts in a number of different jurisdictions to collect data on health disparities and risk behaviors of high school age youth. They administer it every other year, and since 2015, the National Survey has been collecting data on sexual orientation, specifically behavior and identity. We do a lot of work with this data set, and we have been really focused on trying to find what health disparities there are at the intersections of sexual minority status and racial ethnic minority status. And I think we have seen a lot that reflects the things we just talked about in Chicago. There are a lot of national trends that we see, but some of the things we really see are that drivers of health disparities aren't just individual level. There's a lot of extra individual level factors that drive it. Here's one example is that bullying and victimization are really key to driving some of these disparities. Here we see that research from the YRBS shows that people who identify as bisexual or who report sexual activity with both boys and girls were at highest risk for bullying and peer victimization. And for those of you who are familiar with different theories like minority stress theory, people who experience things like bullying, victimization, stigma, tend to have poor mental health outcomes, which then leads to negative coping skills. And that tends to lead to a lot of downstream health effects, which have been tied to HIV infection, substance use, and it's really critical to really think about how these disparities are influenced not just by individual behavior, but by the environment in which people are living. Another example of an extra individual factor that causes these health disparities is documentation. Here's a study that was published a few years ago in LGBT Health that is really focused on documentation status for young transgender Latinas. For this population, as with many Latino and Latina and Latinx populations, documentation is a critical issue. And not having documentation is a key barrier to engaging with healthcare systems. We already know that trans individuals are less likely to engage with health systems, and they have a lot of other barriers, but the overlap between being a trans individual and being an undocumented individual has severely impacted access to services, access to HIV prevention services, and just access to any sort of care services in general. So here's a population we know is already at high risk for HIV, has been highly impacted. And then they have these other factors that are related to their environment that are really causing extreme disparities. Sticking with the focus on Latino populations, here's a study that I worked on with a few colleagues that was looking at differences within the Latino population for men who have sex with men. And as many of you are familiar, I'm sure, not too many people really break down what the racial ethnic identity is of Latino MSM. We tend to think of them as a monolithic population. We look at them the same as we would talk about Black MSM as just one population that is united by racial ethnic identity. But we all know that Latino MSM have a wide array of identities, experiences, and by just collapsing them into a single category, we're missing out in nuances. And these are really impactful, especially when we're talking about HIV. This study was looking at uh, different identities within the Latino umbrella. So people could report a Latino identity plus a racial identity. And here we looked at HIV positivity among Black Latino, white Latino, and other Latino individuals. And we compared it to the HIV positivity rate among Black MSM. As you can see here, the Black Latino MSM were almost the same rate of HIV positivity as Black MSM, but the other Latino and white Latino groups were much lower. And if we just keep collapsing Latino into a single category, we're missing out on this nuance. So we're missing out on who's most highly impacted. So we really want to make sure that what we do is reflective of the populations, but not reductivist, and we make sure that we look at the wide array of experiences within an individual. So here's a good example that even though we think we are being responsive by focusing on differences based on racial ethnic identity, there's still more we can do. And even here, there's more we can do because we could be looking at country of origin, we could be looking at acculturation, time in the country, documentation status, so many other things that we could really be looking at to see who exactly is impacted, because we know it's not just the Latino MSM, it's subpopulations that are really impacted. And not knowing who's impacted is really key to helping us end the HIV epidemic. And finally, a slide about trans women. We don't have great data on trans women. I know many people on this presentation are very familiar with how difficult it has been to get surveillance data on trans populations, especially since data aren't collected in a way that's necessarily gender affirming. It's more based on whatever CDC has set out, and that doesn't always align with what we would hope to see as how people are being defined as male or female or MSM. And that has made it extremely challenging to be able to see what the magnitude of HIV has been on different populations. So we know that an estimated 14% of trans women in the US have HIV, but this isn't necessarily from surveillance data. This is really just from meta-analyses that people have done, because the surveillance data isn't really set up to capture data on transgender populations, especially trans women. And even though it's been improving over time, we still only have a few years of data, even in jurisdictions such as Chicago that have been doing a better job at collecting these data. And for what we do know from this limited data, we know that, again, the same minority populations are the ones that are also greatly impacted within the trans population. So 44% of Black African American trans women have HIV, 26% of Hispanic Latinx trans women have HIV, and 7% of white trans women have HIV. Again, here, thinking more about intersecting identities, people who have multiple minority identities are much more highly impacted by HIV. And I will use that to turn it over to talk more about intersectionality.
Thank you, Gregory. So in some ways, we can summarize some of what we've been talking about under the framework of intersectionality. A lot of you may be familiar with this already, but let's turn to the originator in her own words to get a sense of what we're talking about. Intersectionality. Adoption of a single issue framework for discrimination not only marginalizes Black women within the very movements that claim them as part of their constituency, but it also makes the elusive goal of ending racism and patriarchy even more difficult to attain. So Kimberly Crenshaw shared that with us around how to describe how discrimination, and in some ways we can think of that as oppression at large, marginalizes and acts upon Black women in a way that makes it hard to understand how racism and patriarchy are working together. And so a summary of that understanding can be a theoretical framework for understanding how aspects of a person's social and political identities combine to create different modes of discrimination and privilege. It identifies advantages and disadvantages that are felt by people due to a combination of factors. We know that data collection has a lot of challenges right now. And in some ways, that's a nice way of saying that data collection, at least at the jurisdiction level, hasn't really caught up to how we view and understand and work with the communities that we are trying to serve. We know that there is a lot missing. I know that my program has some work together with our CDPH partners to figure out what some solutions can be in the short term. But I think that Gregory alluded to this at the beginning of the presentation, that some of these mandates are being handed down by federal organizations. And so some of the conversation is about how do we change how data is collected, not just in our jurisdiction, but at large around the country, which is a challenging situation. We have two diagrams here, and they're very different. What's different about these two diagrams? When we're talking about intersectionality, some of the main crux of the framework, so there's something different happening in both of these diagrams. The one on the left where we have overlap, and the one on the right at the bottom where we're just adding experiences together. Sometimes when we're talking about those experiences, our instinct is to add them together. So if I'm Black, so for instance with me, if I'm Black, if I'm Mexican, if I'm gay, then all of those things add together to create an experience. But what intersectionality tells us is that it's a little bit more complicated than that, that there may be some aspects where those add together, but really they mix and combine and create something new. Where, I don't know if you can see my cursor, but obviously our blue and our yellow are gonna mix together and not have a blue-yellow. They're gonna have a green. And yellow and red don't mix together to make a yellow-red. They mix together to make an orange. We saw these in some of the examples that Gregory passed along to us earlier about young Black bisexual women, where their experience wasn't that in some places they were bisexual and then they were young and then they were women, but really that those identities combine to create an instance where they are experiencing more bullying than any of their peers, racial, sexual peers or otherwise. Some of what we presented earlier was really in creating a foundation for a conversation, and a foundation where we're able to share with each other about how we handle what we already know is going on. We have our priority populations, our primary service populations, and we have our deliverables recorded in how we serve and how many of them we serve. Along the way, we may realize that certain parts of those populations are overrepresented more than others. So some ways to react if we're talking about intervention itself, you all have already mentioned this, partnerships, co-locating services. We know that some of the PCHH model is about co-locating services to provide to anyone who walks through the door. In some ways, we might look at what's happening with the HIV Resource Hub and making sure that emergency financial assistance being available there is a version of partnership. And I think the client SSI number, relaxing the need for that is a way that we revise eligibility for services. I know that sometimes housing also has these type of eligibility requirements. So if we look at advocacy as an upstream approach, interrupting how services are funded and how priorities are decided is a way of doing this. Changing policy, which can also include fee-for-service models, and how rates for certain services are decided upon. Sometimes that can happen during the community planning process. Those of you who have been part of CAHISC for years and where CAHISC is evolving into know what the, what's the acronym for it? Priority setting and resource allocation. It's been a while. what that process looks like. That is a way to have your voice heard for the various populations that seem to be creeping up in who is coming to meet us for service. Another way is to have conversations about how data is collected, like how we started our conversation, to make sure that various communities are being counted so that we know how HIV is hitting that part of our community. And surprise, surprise, this is our last content slide. We have almost spent an hour together just going through some of the basics today of what many of you already know. There are many communities who are in need of HIV services, but when we talk about communities, who are we talking about? Gregory went over this with, it's whoever we know needs service during this time. Those are those who are living with HIV, those who are vulnerable to HIV, those who are within their networks. In terms of practice, Jill just gave us another example about making sure that accessibility is high. So with the HIV Resource Hub, or maybe it's called Hub, and I don't know, that's an acronym, HEB, has ensured that people can contact in many different ways: walk-in, phone, text, email, and I'm assuming probably other virtual ways. You all probably have many other examples of accessibility when it comes to telehealth right now. If you are interested in any additional trainings that go into those, like virtual service delivery, please let us know, and we can add that to our slate for next year. Today was really more of an overview of the way that we can conceptualize and address the ways that geography, disparities, and different epi combine to let us know about who is represented and who needs more service. Thank you all for the examples that you've given today. If you're interested in a part 2 that does a much deeper dive on specific practice, on workshopping, any challenges that you may be having at your site, or anything related to that, please let us know. We will be launching our learning collaborative model, it looks like by the end of the year. And right now, after listening to you all, it sounds like quality improvement and quality management is really something to focus on. But if you're interested in tailoring your practice and tailoring your intervention to make sure that it hits those who are most in need, please let us know and we can spend more time delving into that. That said, I want to end on a slide that really recognizes some of the work that's already been going on to answer some of the questions that we've been going through today. So practice and policy, we talked about at length about how these can look, and touched on priority setting and resource allocation as an opportunity for all of you, not just within service delivery, but within funding structures, can have an impact on how this work looks. If you haven't had a chance to participate in any community planning sessions, I would approach your project officer. Many of those have moved to virtual spaces this year as the pandemic has forced us to change how we operate. All of our presentations will be available through Box. You'll be getting a link to our survey and to Box in the upcoming email that we'll have in a little while. You can also check us out by going to any of our social. That means Twitter, YouTube, or Instagram to get additional content. We're looking forward to being bigger and better with each new month and each new year. So please let your voice be heard about the type of content that you're looking for. And on behalf of the Evaluation Center, it's been a pleasure to present to you today.